Welcome to the US2 support group meeting and webcast on radiation therapy. I'm Chuck Strand, CEO of US2 International. We are a prostate cancer nonprofit focused on providing educational resources and support services to the prostate cancer community at no charge. And we'd like to thank all of you for joining us here tonight, and we'd also like to thank Augmentics for sponsoring this webcast, in addition to the physician presenter, oncologist Dr. Dan Freed, along with Johnny Payne, leader of the US2 Greenville support group, and Joe Dickey, who leads the US2 Spartanburg support group. These support group meetings really help provide the education and the perspective that's necessary for people to be able to make informed decisions on prostate cancer on all aspects of the disease. And the core strength of the organization of US2 really lies in the commitment of these amazing people like Johnny and Joe, who really dedicate their time and their talent and their energy to leading these US2 support group meetings throughout cities across the country. This gathering here tonight in Greenville, South Carolina is one of hundreds of support group meetings that take place each month. And we recognize that not everyone is able to make an actual support group meeting just due to the fact of geographic or physical limitations. So we're especially excited about this webcast tonight, which opens up the support group meeting experience to everyone, everywhere. And for those of you who are watching the webcast online, we invite you to submit questions through the comments field at the bottom of the screen. We'll do our best to answer as many questions as possible during the webcast, and we'd also appreciate your feedback on the effectiveness of the webcast by completing a post-event survey, which we'll send to you through email sometime early tomorrow. And there'll be two additional webcasts from US2 taking place over the next month. One's going to be on chemotherapy, and the other one will be on advancing prostate cancer. And also wanted to note that US2 provides additional opportunities for prostate cancer survivors and caregivers to give and get support through the Inspire online prostate cancer community and through regularly scheduled conference calls in collaboration with ANCAN. If you haven't already done so, we encourage you to check out the US2 website for details on opting in to receive these emails with information and education. Our web address is www.ustoo.org. That's us2.org. And for the past 13 years, Terri Likowski has been a dedicated member of the US2 team and the point person for partnering with the US2 support group leaders. She has recently taken on additional responsibilities as the US2 Program Director of Support Group Services, where she leads initiatives to help support group leaders with additional information and resources and shares best practices for efficiency and effectiveness. So please join me now in welcoming Terri Likowski.
Thank you, Chuck. So being part of this organization has made me a better person. I can truly say that, and it's been a really rewarding experience. We talk about the magic that happens when we're able to bring people together, whether it be face-to-face at a group meeting like we are here today, live streaming an event, which I'm really excited that we're also doing today, whether it's a phone conversation or families being brought together at a Sea Blue event. When that connection happens, it's a really powerful thing. I'm the point person, like Chuck said, for all the support groups throughout the U.S. and some internationally. And one of the things that distinguishes us, too, from other prostate cancer organizations is our support groups. Most of these groups are volunteer-led, and I know many of you out there are joining us today, and I just wanted to take this opportunity to thank all of you for your dedicated service to this organization. Thank you all so much from the bottom of all our hearts, the staff and the board of directors. Without you, we couldn't do what we do in our job so well. And everyone, you're all my mentors, and I have the utmost respect for all of you out there, so thank you. The past few years, the leaders have expressed a need for better support and interaction and collaboration with each other in the network, so that they can help improve the services to us too in the communities. So one of the new resources that we're providing now is it's a support group for support group leaders. It's actually a phone call that takes place, traditionally it takes place 2 times per month. And we've been doing these calls since last October. The calls are permitting us to have a platform to exchange and share excellent information, and it's a cross-pollination of ideas where we can all share best practices and learn from each other. I love it when we have these calls. For an example, one of our last calls, we had some people on the phone that were from Florida, and we had some folks that were from Alaska, and then everywhere in between. So it's a really cool thing to experience. And again, it teaches everyone that they're not alone out there, and that we're all here to support each other and share with each other. So it's clear from the calls. We've gotten great reviews, and they love the calls. They keep coming on every month. We can have anywhere between 25 to 40 leaders from across the country on these calls. So they've been extremely successful. Besides providing the educational materials free of charge to our groups, we also have a new space on our website called the Support Group Leader Resource page. The site was created to be an interactive site so that leaders can just jump on and use the site on a regular basis. Notes from the calls we have every month are posted there, and then we're constantly posting new information, presentations, and things that you can share at your support group meetings. So it's becoming a really great, interactive site where it's really helpful to all the leaders. Another initiative that we're working on that we're excited about is most of us admit that caregivers are the gatekeepers to our men's health and our families. So we're discussing new ways to encourage caregivers to start new support groups, and we're coming up with some new materials specifically for caregiver groups. So if anyone out there is interested in starting a caregiver group, please contact me. You can visit the S2 website to learn about any of the groups that we have throughout the country. So I'd like to consider anyone listening who's interested in becoming a support group leader to please contact me. We have some brand new videos on our websites from other group leaders sharing their experience. And if you go on and check out those videos, you'll see that it's been a really rewarding and fulfilling experience for all of them. And like I said before, the magic is real. It's really there. So it's my honor to introduce Johnny Payne, the S2 Harvey Floyd Support Group leader from Greenville, South Carolina, and he's also one of the winners, the recipients of our S2 Edward C. Capps Hope Award. So thank you so much, Johnny, for all your work tonight, for making this happen. Thank you.
Thanks, everybody. Thanks for coming. Before I introduce Dr. Freed, I'd like to go over a couple of things. One of the things that we always do to what we are newly diagnosed, and there's a couple of folks who are here for the first time, and we have what we call our newly diagnosed kit, and it has just a lot of information and resources in it. So if you are, especially if you're in the process of trying to decide what treatment you're going to go through. So this you might find this very beneficial. So I will give this to you later tonight. And if I don't have enough for everybody, I've got some others at home. I can also bring that. Also, now we would like to bring on our speaker for the night, our medical speaker, Dr. Freed. He's no stranger to some of us. And like Bob said in the introduction, the first time Dr. Freed was here, we lost power. Hope we don't lose power tonight, because we got people all over the internet watching us. But just a little bit about Dr. Freed, and like I say, he's not a stranger to most of us. But he did his undergrad, I understand, at the University of Chicago. He has earned a master's in public health in biostatistics from the University of North Carolina, a PhD in entomology at the University of North Carolina. Now, as far as his medical education goes, he did that also at the University of North Carolina in Chapel Hill. He did his residency also there. And he did his internship at the New Hanover Medical Center. He's been an assistant professor at Wake Forest University. He's been an assistant professor at East Carolina. And he's held positions at Gibbs Gibbs Cancer Center and Research Institute in Spartanburg and in Pelham here. He's also the radiosurgery director at Gibbs. And he's also the medical director of radio oncology at Bon Secours St. Francis. Now, here's for the important stuff. He's married to his wife Francesca, has 4 boys, ages 15, 13, 11, and 9. He spends a lot of time traveling throughout the Southeast. He likes soccer and he likes cross country. And in his free time, if he has any, and he admits he does not have much free time, he still tries to be a bike racer. So that's all I've got on him, and if he wants to share anything else, he's welcome to. But at this time, let's bring on Dr. Daniel Freed.
All right. All right. Well, I really appreciate the opportunity to be here. It really is a privilege to be able to speak to this group. I always enjoy talking to the US2 groups. A lot of very knowledgeable folks here. Sometimes the questions are a little too tough, so you're going to have to be a little easy on me today. Today, I'm going to talk with you about what I think is really one of the biggest advancements in radiation therapy for prostate cancer in the last few years, and that is the ability to place a gel spacer between the prostate and the rectum in order to move the rectum out of the way and do a better job of protecting it when we treat with radiation. So I'm going to see if I can run all this stuff. Am I allowed to take this microphone with me? Can we? I'm going to have to do a little dance for you. Wait a minute. All right, let's try that. Okay, because I like to be able to move around a little bit and point at things and so forth, okay? So now, let's see. There we go. So just briefly, as my only disclosure is that I do a fair amount of work with Augmenix. That is the parent company of Spacer, which is the water-based gel that we're going to be talking about tonight. I don't receive any direct compensation from them, but Spartanburg Regional and Gibbs Cancer Center do get a small amount of compensation when we bring in doctors to train with us or other people from the company to train with us about how to do this procedure. So briefly, I'm going to tell you a little bit about prostate cancer. You all already know about prostate cancer, so I'm not going to go into much there, but just sort of to put things in context. We'll talk a little bit about prostate cancer, a little bit about the treatment options for prostate cancer, and then more specifically about something called radiation proctitis, which is a side effect that some patients experience when they've had radiation for prostate cancer. Then we're going to talk about that spacer gel and whether, first of all, how does it get in there, which is what a lot of patients that I see want to know, and how well does this work, okay? And finally, we're going to talk a little bit about Medicare coverage for this, because that has certainly been an issue in that it is a very new procedure. And as we know, Medicare sometimes has a little bit of lag between when we find good evidence that something works and when they actually cover it. Okay, so as I'm sure all of you know, prostate cancer is a very common disease. According to the American Cancer Society, a projected 161,000 new cases will be diagnosed in 2017. We also know that even though a lot of prostate cancers are rather indolent and we don't need a lot of treatment for them necessarily, it is also true that prostate cancer is the third leading cause of cancer death in men in the United States. So we can't just say, oh, it's just prostate cancer, don't worry about it, okay? There are many of these cancers that are very serious problems, and we need to take them seriously. Okay, so here's a few numbers for you. This is the audience participation part of the show. First of all, so anybody, any guesses about 1 in 7? What does that represent? Yes?
1 in 7 men will get some sort of prostate cancer.
Right, so 1 in 7 men diagnosed with prostate cancer during his lifetime. Okay? What about 66?
Average age.
Exactly right, average age. These are too easy. Okay, 1 in 39. Yeah, so this is the chance that a man in the United States will die of prostate cancer. And finally, 2.9 million. Yeah, so this is the number of men who are living with prostate cancer in this country. It's a huge number of men. And a lot of those men have had treatment for their prostate cancer, and it is possible that those men have some significant side effects. And one of those main side effects is we're going to talk a fair amount about tonight. Okay. Whoop. Let's go back here. Okay, so this is just a quick snapshot of some of the main ways that we treat prostate cancer. One of those, obviously, surgery being the most common way that prostate cancer is treated in this country. But for some patients, they opt not to do surgery, or as men get older, they tend to be less good surgical candidates. So at that point, we start to gravitate a little bit more toward this radiation therapy. The primary way we do that is external beam radiation, but there are other forms of radiation as well. And now, a growing segment of patients, we do something that used to be really called watchful waiting. Now we refer to it more commonly as active surveillance. Okay, so if somebody chooses radiation therapy, let's just talk briefly about what are the goals of treatment. All right, so the main goal is to treat the prostate to a really high dose with radiation, and we know that the higher the dose you can deliver to the prostate, the better your probability is of getting rid of the cancer. But we need to balance that with our need to avoid damaging the normal structures that surround it. So as realtors will tell us, the issue is location, 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 right? The prostate, if you had to pick where to put it, that's not where you would put it, okay? Because the prostate right here is right in the middle of some very sensitive things, all right? So it is directly behind, or directly in front of the rectum. The bladder sits right on top of it. The nerves that control erectile function come down here and run right alongside of it. And the area called the penile bulb, which is down right in here, which we think is at least some proxy for problems that can result in erectile function for men receiving radiation therapy, this is right below it. Okay? So it's in a very sensitive area, and that has the potential to result in a variety of different side effects, including problems with bowel function, urinary function, and sexual function. Now, the one we're going to talk primarily about today is bowel function, but bear in mind, actually, as we go through this presentation, that even though the expectation for the use of this gel was that it would help bowel function, we find actually that it does have even some impact on urinary and sexual function. All right, so first of all, let's talk a little bit about this thing called radiation proctitis, okay? Here is a picture, CT scan of the pelvis, cut through kind of right here, all right? Now, this is a patient lying on his back, his head that way, legs coming out towards you this way. And this is the pubic bone in front. Here we see the prostate. And we also see this area right here is the rectum. Okay? We can see they are very, very close to one another, and that creates a significant problem. Here we see a margin that is built in whenever we do radiation planning, because we know that there's the potential that there can be microscopic disease that extends outside of the capsule of the prostate. We have to account for that. And there also can be motion of the prostate both between treatments and during a single treatment. So we have to build in margin in order to account for that as well. So if we're treating right here well into the front wall of the rectum, this can be the result. So this is an endoscopic view, or like a colonoscopy view of the inside of the bowel. And this red stuff here is inflammation caused by radiation, a high radiation dose being received by that part of the rectal wall. And the result of that in terms of symptoms can be things like bleeding, increased frequency, urgency with bowel movements, the increased mucus production, and these are all short-term issues, but long-term you can run into much more significant issues, and we'll talk about that in a moment. Okay, the other thing to bear in mind is that the risk of injury to the rectum is directly related to how big a volume of the rectum gets a high dose of radiation. So the more we can limit that, the lower the risk is going to be of having any of these bad radiation proctitis outcomes. All right, so let's first talk about what's called acute radiation proctitis. All right, acute proctitis being what can happen during the course of radiation or maybe up to several weeks following radiation therapy. Again, what we can see is that it's actually very common to have these sort of short-term issues. Up to 3/4 of patients actually get some short-term radiation side effects. Those things can include things like diarrhea, rectal urgency, something called tenesmus, which is sort of the urgent need to have a bowel movement, even though you actually don't have to have a bowel movement. They can have things like abdominal and anal pain, and even occasionally bleeding, even in the very short term. Now, for these things, really we just do something symptomatic to relieve those problems, Imodium for diarrhea and so forth. Sometimes a rectal suppository to help decrease some of the inflammation. But usually for these acute issues, not anything really dramatic that we have to do. All right, but what about the chronic problems? These are the things that happen months or years afterwards, and they can be recurrent or persistent problems over a long period of time. This happens much less frequently. About 2 to 20% of patients have some amount of this chronic radiation proctitis, but when it happens, it can be really quite a serious problem. So again, we can see some of the same issues with bleeding and mucus discharge and diarrhea, but we also see these really bad things here with obstructions of the bowel, stricture formation, and even things like perforation where you got an actual hole in the bowel, and that is a very, very serious problem. Okay, so typically when somebody has a chronic radiation proctitis, we start off using medical management. That is, that we might do something like an enema. And those enemas contain a variety of different things that sort of help reduce the inflammation that can happen in the rectum. If that doesn't work, then we can consider doing something like this, hyperbaric oxygen treatment. This is where a patient is placed into a high oxygen environment and is and has to go for a significant number of treatments. So this would be something that is expensive and is very time consuming, and the limited data out there on it show that it works marginally well. Well, if that doesn't work, we can think about doing something endoscopically. That is, go in there and try to fix something. And we can do that with something called topical formalin, where we kind of spray in that area and try to decrease the inflammatory process that's going on. Or use a laser to achieve the same thing. In this situation, where we can see something called an argon plasma coagulation system, which is good for kind of a wide area of problem, where you're just going in there and you're trying to really limit the continued problems there with bleeding and so forth. But these things also have the potential to cause problems. We're trying to get rid of one problem, but in doing that, we can actually cause other problems. Now, finally, we have surgical management. So this is, everything else has failed. We have a really significant problem with things like strictures having formed, or fistulas, which are holes having formed. And maybe you have a bleeding problem where you just cannot get the bleeding to stop and you have to go in surgically. I know that's kind of a gruesome picture and that's a little bit of an overstatement, but you get the message, right? All right, so now the problem with that is you're giving a big operation in an area that has already received a bunch of radiation, and radiation in the long term tends to impair healing and cause other problems. So you do this big operation, but you have a significant chance of having problems with developing another hole, or making a leak, or having a problem with wounds that just won't heal properly, or even really bad infections that can result from that. So really, we absolutely want to reserve this for our absolute last resort, okay? So radiation proctitis, even though it's not super common, and I don't want to scare off our radiation folks in the crowd who are thinking about getting radiation, it's a great way to treat prostate cancer, just so you know. But I want you to realize there are some significant issues that are potentially big problems from it, all right? Now, so wouldn't it be great then if we could prevent that from occurring? So the thing that we've had recently for that is something called the endorectal balloon. And it is just what it sounds like it is and looks like it is. It's a balloon that you put into the rectum. Now, you do it prior to each treatment. And you can see here, this is another CT scan image. We can see here's the pubic bone in front, the prostate sits right behind that, and here's the rectum, and it's been distended by this balloon, and you can see the lumen of the balloon here. There's a little, you can see this little sort of stalk right here that is right here in the scan. Now, this had been used for a number of years in trying to decrease the risk of having injury to the rectal wall, and what it was able to do is expand the rectum, and in doing that, could move the sides of the rectum away. It could move the back of the rectum away from the radiation area, but the problem with it is it actually moves the front wall of the rectum even closer to the prostate. Now, when you do that, you're actually compressing a fat plane that exists between the two structures, and you're pushing the front part of the rectum right into the prostate. Okay? When you do that, you actually have the risk of increasing the high-dose rectum that gets treated, okay? So the volume of that high dose can go up, and as we talked about before, that's directly related to the risk of injury to the rectum. So the question is, okay, well, first, for endorectal balloons, the other issue with them is they're quite expensive, okay? Each of those balloons, I know it doesn't look like much, but each one costs like $100, and you don't reuse them, as you might imagine. Don't want to anyway. Okay. So now what that means, now the other thing is Medicare only covers 2 of those balloons. Now we use one for a CT scan before the treatment, and then we use 44 of them during a normal treatment course. So 45 balloons, but they only pay for 2 of them at $100 a piece. So what that means is that somebody is paying all the rest of that. Now, it may be the hospital, it may be that the hospital tries to pass that charge on to the patient somehow, but somebody is absorbing the cost of that, and it is not trivial. All right, the other thing, it's uncomfortable, right? Who wants that thing in there? And especially as you get toward the end of the treatment course and things are really getting to be uncomfortable even without a balloon going in there. This is the facial expression that we most commonly see, especially as you get into that last week of treatment. Not pleasant. All right. So then the question then becomes, all right, rectal balloons, not so great. I mean, they're used by some doctors. They were not used by others. I personally didn't use them, but 2 of my partners who do a lot of prostate radiation were using them. But my feeling was that I had too much concern about that front wall of the rectum moving into the radiation field that I was not comfortable using them. And the data kind of inconsistent in terms of whether or not they were really effective. So the question then becomes, missed it. Is there anything better, right? All right, so this is an email that I got from one of my physicists in January of 2015. Now, this gel that we're going to talk about, it got FDA approval in April of 2015. So about 3 months or so before that approval, I got this email. And it basically said that he had seen what he called an interesting product, and his prediction was that this could perhaps replace rectal balloons. And it turns out, in our practice, he was 100% correct. Okay? Now, it took us a little while to get that going, that program going, but not very long, because FDA approval happened in April of 2015, and we started our SpaceOR program in August of 2015, just 4 months later. Okay, so let's talk a little bit about that gel. Okay, again, we've looked at prostate and rectum. They're really close to each other. This red area represents the high-dose region of radiation, and you can see it goes right into the wall of the rectum. Here is the same patient with the spacer gel placed, and you can see that none of that high dose actually goes into the rectal wall anymore. So what it does then is to protect the rectum from the high dose of radiation. This is a gel that's injected into that space, and in a minute we'll talk about how in the world it gets there. And it provides about 1/2 inch of space between the prostate and the rectum. Now bear in mind, what you've got there to begin with is 1 to 2 millimeters, so very, very little space. And I'll show you in a minute just how thin that space is when we look at some ultrasound images. Okay, so now what it does then is push the rectum backward and away from the prostate. And it significantly reduces the radiation dose that's received by the rectum. All right, so now let's see. All right, so the other thing, as we talked about before, is you can have motion of the prostate as you're treating or between treatments, and because of that, now you can see here, it's a pretty subtle thing, but you can watch the prostate moving very subtly there all around in that, right? And you can see actually that when that happens, you can actually have a situation where even more rectum moves into the high dose region than you had expected. Okay, so let's look a little bit, a couple of schematics here. One of these, this first one shows a patient lying on his back, legs up in stirrups, a little bit of a compromising position for a man to be in. Women, the wives always get a chuckle out of it when I tell them what's going to happen. The husband's not so happy about what's going to happen. But with our patients, they're asleep during the procedure, so they don't really know much about what's going on. All right, so legs up in stirrups. This is the rectum, and an ultrasound probe is placed into the rectum, just like the one that is used when you do a prostate biopsy. Then here's the prostate right here. This is the needle and the syringe apparatus for placement of the gel. And the needle actually goes through the area of skin called the perineum. That's the area of skin just behind the scrotum in front of the anus. So rather than how urologists do a biopsy of the prostate, which is take a nice sterile needle and you stick it through the rectal wall and into the prostate, where no matter how clean your needle was going in, it's not very clean when it gets to the prostate, and you can have actually a fairly high risk of infection because of that. When we do this procedure, we sterilize that area of skin, we take a sterile needle and place it through there, and the rates of infection for this procedure are incredibly low. All right, here you can see prostate again. This is the rectum with the ultrasound probe in it, and this is the gel being placed into that space. Again, this is the back edge of the prostate, and this is the front edge of the rectum, and you can see that it really just pushes those structures away from one another. All right, so this procedure can be done under local anesthesia or a general anesthesia or kind of a tweener, and that is something called MAC, which is a monitored anesthesia care. This is how we do most of our patients. It's just some medicine given through an IV, and patients sleep through the procedure. So this gel, so it starts as two liquids, goes through this adapter, and immediately turns into a soft, solid gel. Now, a lot of people, when they think about two things coming together and making some other thing, they think about epoxy glue, and it makes all this heat, and they're worried, is that just going to burn everything up? But it turns out no heat generated at all from this procedure, okay? So you don't have to worry about the epoxy glue effect, nor is there any glue in it. All right, so all right. I think I'm running out of juice here. Okay. So the gel itself is 90% water and 10% polyethylene glycol, and it's actually formulated to stay solid and in place for about 3 months, and then it will slowly dissolve following that. And it will liquefy and be resorbed into the body and then excreted as urine. So it gets completely eliminated. Okay, so here is an ultrasound image. I'm going to show you some pictures. I'm going to play a little video for you in a minute, but I want to just show you the anatomy first so you know kind of what to look for here. And this is actually a video of one of the procedures that I did several weeks ago. This is the prostate right here. The ultrasound probe itself is down in this space right here, and this part is the rectal wall. So you can see this is the fat plane. This white strip is the fat plane between the prostate and the rectum. You almost can't even see it. It's so close, right? Those structures are really just smack right up against one another. So let's go ahead and play that. So here you can see the needle, and that needle, let's see, should be moving. There we go. So you can see it moving. Each time that there's a little opening of that space, it's a little puff of saline that goes in there, okay? So here we see again, giving a little puff of saline just to make sure we're in the right spot and to kind of open up the space there between the two structures. Now you can see this image is an axial image. It's kind of cut through here. You can see we're just making sure that it's a symmetrical rise of the prostate here as we inject that. And you can see this black area right here is the saline that we're putting in. So back to the image that's sort of cut down like this, the sagittal image. We're going to go in again. We're going to try and make sure we got the needle tip in just the right spot where it sort of rises symmetrically. And you can see, give it a little rise, a little poke there. And now I'm in the process of swapping out the saline syringe for the double-barreled syringe that has the gel components in it. And then you'll see the gel being inserted here into this space. So this is all gel. So you can see that rise. This is the space between prostate and rectum now. All right? So really just pushes the structures apart from one another. Okay, so here we can see this is before, this is an MRI image, prostate, rectum, and here's a little fat plane. We can see 3 months after the placement of the gel, it's still there and providing really good space. And here we are a while later where it's just gone, it's been resorbed and excreted. Okay, so looks really cool, but the question is, does it work? All right, I'm going to tell you about the main clinical trial that led to the FDA approval of Spacer, and that is one that is called the U.S. Pivotal Study. And in summary, this was a study that was a randomized trial, meaning the flip of a coin determined whether patients were going to get just markers placed into the prostate to be able to target the prostate properly, or whether they were going to get the combination of the markers placed and the gel. So the patients actually did not know whether or not they got the gel. 222 patients from 20 U.S. sites, all of whom received external beam radiation, IMRT, good modern intensity modulated radiation therapy. And just so you know, in terms of the anesthesia, a fairly even distribution between the general, the local, and the MAC. Most of these patients did receive antibiotics following the procedure. When we look at how doctors felt about this, 99% of them said this was an easy or a very easy procedure to do. And we also see that in terms of the percent of patients who went for the procedure who could actually receive it, 99% were able to do that. So the vast majority of patients who were intended to get the gel actually wound up receiving the gel. Okay, so what we see, though, is in terms of safety, there were no adverse events reported from this out of 222 patients. Nobody was delayed in starting their radiation therapy. That there were no infections. So 222 patients, if you did biopsies on 222 patients, you would have a bunch of infections from that. Okay, again, it's the difference between going through the rectal wall and going through the area of skin, the perineum. Now, the other thing to bear in mind is about a half an inch of space was created in between the prostate and the rectum by this. And when we look even at 12 weeks, the vast majority of that space was maintained, and then it began to dissolve following that. Okay, so in looking at the results from this, so again, 1.3 centimeters or about a half an inch of space resulted in much less of this high-dose radiation being received by the rectum. It resulted in much less rectal toxicity and in improved quality of life as reported by patients. And we'll go into some detail about each of these in just a second. So when we look at the dose received, we worry about this, what we call the V70. The V70 is the volume of rectum that receives a high dose of radiation. The bigger the volume is, the worse patients tend to do, or the higher the risk is of injury to the rectum. So what we see is that significantly fewer of the patients had a high V70, or a lot of the rectal wall receiving a high dose of radiation. We also see that this area that we talked about, the penile bulb, which seems to be related to the inducement of erectile dysfunction by radiation, that was actually reduced in this population. That is the patients who received the gel. When we look at rectal toxicity, this is late rectal toxicity, so those patients with that chronic problems, we see here those with grade 1 or higher toxicity, that is, grade 1 is mild, grade 2 is moderate, grade 3 being severe toxicity. We see that there was a significant decrease in the percent of patients who had late grade 1 or greater toxicity. And also, when we look at the grade 2 toxicities, we see 6% of patients in the control group, that group that didn't get Spacer, had grade 2 or higher toxicity, but none of the patients in the Spacer group had a grade 2 toxicity or higher. When we look at sexual benefits from this, we see if you started out looking just at the men who were potent at the time of their radiation. Now, a lot of men, of course, as they age, going to have some diminishment in erectile function. So we're starting with just the men who had good erectile function at the beginning. And what we saw was this, that if you look at the control population and you look 3 years later, only 37.5% of those men still had good erectile function. Whereas if you looked at the group that received the gel, 66.7%. So, you know, a really quite dramatic difference in the ability to retain erectile function 3 years out from the procedure. Now, the other thing we're going to talk about is some patient-reported quality of life indicators with something called an MID, a minimal important dose. So this is basically saying this is how, or difference, I'm sorry, a minimally important difference. This is basically saying that we're going to talk about differences between patients, only ones that we think are actually meaningful, not like some little tiny difference, but one that's big enough actually to make a difference in their quality of life. And what we see here is when we look at sexual quality of life at 3 years, a borderline significant improvement for those patients who received the gel versus those who didn't. So again, we went into this expecting that rectal issues would be improved, but what we find is not only do those rectal issues improve, but also sexual function improves, and in fact what we'll see is some issues with urinary function are better as well. So if we look at the urinary benefits, we can see here that there is a significant difference in the urinary incontinence rate here at around 14-15% versus only 4% for those who received the gel. Now, we're still in the process of trying to figure out exactly why it was that we saw these big differences, but the reality is in this very well-controlled study, this is what we saw. Okay, so the last thing I'm going to show you with this is something that we refer to as overall benefits. This is asking the question, if you incorporate rectal quality of life and urinary quality of life and sexual quality of life, and you look at the difference between the groups, then what you see is that 20% of patients had significant decrement or decline in all three of those things at 3 years if they didn't receive the gel, versus only 2.5% having that significant difference if they did receive the gel. And if we look at this 2 times the MID, that is a really even bigger difference in the quality of life domains, what we see is 12.5% had that big difference if they didn't receive the gel versus none of the patients if they did. Okay, so just a quick summary. We know that it can be done reliably, and we see that in 99% of patients we can actually do the procedure. That we know that it reduces the high dose of radiation to the rectum, and we know also that if we're looking at clinically meaningful late toxicity reductions in bowel quality of life, that if you look at the control group, 1 out of 14 patients had a grade 1, 2, or 3 toxicity, okay? That means anywhere from mild to severe toxicity. If you look at the Spacer group, only 1 out of 49 patients had any problem, and it was always a grade 1, okay? Only mild. So really, I think a very dramatic difference there. Okay. So let me tell you just briefly about our program. As I said, we started our program back in April of 2015 over at Gibbs Cancer Center. In August, we did 4 cases, and we were the first center really to get a program up and running in the North Carolina, South Carolina, Georgia area. At this point, we've done about 225 cases total. A lot of those actually for patients who receive something called CyberKnife, and that's something that I think I spoke with this group about before, but at any rate, if there are any questions about that, I'm happy to answer that. We actually did present data on that at our big national meeting just last week. So we are the first space or National Education Resource Center, which we lovingly call a SNERC. And that means that people come to us to train, to learn how to do the procedure, or folks from Augmenics who are new hires, and in fact the company is growing very rapidly with the gaining in popularity of the use of this. We train a lot of their people in terms of how to do the procedure. Okay. So let's talk a little bit about Medicare coverage. All right, this is the last thing I'll be talking about. Medicare coverage is actually changing very rapidly and is a big concern for a lot of patients with very good reason. The procedure is not cheap, and for patients who have to pay for it out of pocket, it's a really big deal. So in our practice, for those patients who have not been able to get covered either by Medicare or their insurance company for the last 2+ years, the hospital has actually been paying for that procedure, or at least paying for the gel kit, which is almost $3,000 expense. But unfortunately, there are not a lot of places that have been willing to absorb the cost of that. We felt that it was, number one, in our patient's best interest, and number two, we already were using a lot of those balloons, and as I was explaining to you, those balloons are not cheap. So for us, it wasn't a huge additional expense, but we felt as a practice that it was a much better thing for our patients. So let's talk about what is now becoming a very compelling case to cover this procedure for patients across the country. First of all, there are over 60 peer-reviewed publications now. And now this is a very new procedure, and so to already have this number of publications is really quite impressive, including now some 5-year follow-up data on some early work that was not in a randomized trial, but the randomized trial now with 3 years of follow-up. We see that it has been recommended by a number of societies, including the American College of Radiology, including ASTRA, which is sort of the parent organization for radiation oncology, and that it's now included in the NCCN guidelines. So the NCCN guidelines are the organization basically that we all turn to as oncologists to ask what are the standard practices now for treatment of any cancer type. So also, there's been positive review by a number of third-party health technology assessments. And most recently, the Palmetto MAC, which is the organization that makes recommendations about Medicare coverage for North Carolina, South Carolina, and a number of nearby states, has approved this as a covered procedure as of today. So this is something that a number of us have been fighting for the last 2 years, and as of today, this is a covered procedure in South Carolina. We can see at this point over 15,000 of these procedures have been performed worldwide, over 10,000 of those in the United States. So the other thing to bear in mind is even in places where there is not coverage officially, there is a lot of help in terms of getting coverage, and in fact, Augmenics has a whole team of people that are prepared to help with that. So if a physician and a patient feel that this is the appropriate thing to do, they will help as much as they're able to make that happen. All right, so finally, radiation-related side effects are of significant concern, especially those issues with radiation proctitis. That compared to control subjects, having the rectal hydrogel spacer has been demonstrated to decrease radiation dose to the rectum, the late rectal toxicity that we were so concerned about, the decrease in erectile function, and urinary incontinence rates. And it has been shown to improve quality of life for bowel, for urinary function, and for sexual function. And coverage is expanding quickly. As I said, as of today, the number of states increased by 7, and I think that that is going to be really a changing landscape over the next several months. All right, well, I appreciate your attention. I welcome any questions.
I'll bring the microphone over to you so you can use it for asking your question. There you go.
Maybe I missed it, but you mentioned that the gel eventually dissolves, and what happened to that space in there that the gel just came out of?
So the space just closes back up.
Just closed back up?
Yep, so you just don't see it anymore.
Okay.
I don't know. I got a brother-in-law that has prostate cancer, and I've been trying to encourage him to come to these programs, but he won't come. I can't twist his arm. He's bigger than I am. But I'm thinking that, well, my question is too, some people have told me that they have their prostate removed, and they don't even do the radiation treatment. So is there a side effect when they have it removed? I mean...
Yeah, so the side effects of surgery are certainly different from the side effects of radiation therapy. So we talked a little bit about radiation therapy-related side effects, primarily affecting bowel function, urinary function, erectile function. Well, when we think about surgery, again, it's all based on anatomy, okay? When you remove the prostate, the first thing you try to do is peel the nerves that control erectile function off the sides of the prostate. In doing that, there is invariably some amount of damage done. So erectile function is a big issue for a prostatectomy, which is surgical removal of the prostate. Also, you're cutting an area just below the bladder, basically between the bladder neck and the prostate, and then you're cutting again down at the pelvic floor at the bottom of the prostate. You pull together the ends of the urethra, and then it heals from there. But in doing all of that, there is often some damage to the ability to control urination. That is the biggest complaint for patients who've had a prostatectomy is urinary leakage and incontinence. Whereas from radiation, we worry primarily about damage to the rectum more than anything else because we tend to have less in the way of urinary toxicity for the most part. But we do have that issue with potential radiation proctitis. For surgery, the biggest issue tends to be a leakage and incontinence problem.
Okay. Okay. All right. I don't... I'm getting used to this mic. I had enlarged prostate, okay?
Yes.
And they did test on me. I didn't have cancer, but I got the incontinent later. Not excessively, but I have it. So I guess what I'm trying to say, I'm good, right? I mean, I don't have to worry about getting no cancer.
So here's what I would say.
Yeah.
It's great that you don't have cancer.
Right.
But that doesn't mean you cannot develop cancer. So you should be vigilant about screening for prostate cancer. You know, there's been a lot of discussion over the last several years about PSA screening for prostate cancer. And for many years, the recommendation had been men over a certain age, they should do annual screening for PSA to give us an indication if there are people, if those men should receive a biopsy to try to diagnose prostate cancer and so forth. But then the U.S. Preventive Services Task Force several years ago came out with recommendations really against the routine screening with PSA. I think what we found is that they are really relaxing their view on that as we find that the studies that we based that recommendation on, or that they based that recommendation on, were very flawed studies. And what we're finding now is that we are actually missing a number of cancers that we should have found because we're not doing as good a job with PSA screening anymore. And now I think the pendulum is swinging back the other way, and we're going to start doing PSA screening. Now, I would never make the argument that PSA is the perfect screening tool because it does have a lot of flaws. But it happens to be the best thing that we have available right now, and until we have something better to replace it, my feeling is don't throw it away, okay? Right. So my feeling is you still need to get screened on an annual basis.
Really?
Because, yeah, really.
But my PSA I've been checking on it every year, and you know the urologist checked me, and he tell mine stays low,
Yes.
which is good,
Yes.
right?
That's good.
And I had the drill. That's not the proper
Some people
term.
call it the roto-rooter. Yes.
But you know what I'm
Which
talking
is something,
about.
yes, something called a TERP.
Term. That's
Yes.
Yeah.
So my feeling about it is this, that again, it's a great thing that you do not have cancer currently, but we have to bear in mind that you can still develop cancer even if you don't have it right now. And so it's still a good idea to be vigilant about PSA screening. Now, how old are you? 69. So you're still in that age range where we feel it's important to do PSA screening. Now, as men get significantly older than that, then I think it is reasonable to, especially if they have significant other health issues, then I think it's reasonable to stop PSA screening. But I think until you get significantly older, or unless you have a lot of other medical issues, I would continue to screen. Yes?
For a while, the PSA was still low. Okay. For a while, the PSA was still low, but 3 years later, it started rising, so I had to get radiation.
Yes. So,
is that kind of normal? Or?
So that's a very common scenario. That is, somebody has a prostatectomy, and it does well for a while, but then the PSA starts to come back up. And when it does, the only curative option at that point, assuming that it's still all localized to the prostate bed, is to treat it with what we call salvage radiation therapy, okay? Which sometimes is done in conjunction with hormone therapy and sometimes not, but can be effective at getting rid of the cancer even in a situation where it's come back after surgery.
That's good. Okay, can you take an MRI instead of biopsy?
So that's a good question, and that's something that we don't have a great answer to at this point. And that is, can you just get an MRI instead of doing a biopsy? Yeah. And I think we are not yet there in terms of MRI technology. Now, MRI is probably the best scan that we have available for imaging the prostate and the area of kind of the local area in the pelvis. But, and often it will show nodules in the prostate where we might be concerned, and then we wind up doing, even so, a biopsy of those nodules to confirm that they're actually cancer, because sometimes you'll see a nodule and it actually doesn't contain cancer. But the other issue is this: sometimes you won't see a nodule on an MRI, and there will still be cancer in the prostate.
Well, I haven't had a biopsy probably in 10 or 15 years. But when I go to my urology, they check me out and said mine's so low I won't give one.
Okay, so if you have a low PSA,
2.5.
Yeah, so a PSA of 2.5, I wouldn't do a biopsy. In fact, I wouldn't get an MRI at a PSA of 2.5. Unless you were having a rise in PSA or you had a sudden jump in your PSA that took you, say, from 1 up to 2.5, that might trigger some a workup. But if you've had just a slow, steady rise up to 2.5, which is very typical for men as they age, because prostates grow under the influence of testosterone over time. So it's not surprising that men have enlargement of their prostates, and because normal prostate tissue makes PSA, that your PSA would go up along with that. Okay? So as long as it doesn't get very high, then no, I wouldn't do I wouldn't do a biopsy of it. Yes?
A multi-part question here. You mentioned the study of 222 patients. Do you know what was the youngest age, oldest age, and average age of the patients in that? Secondly, of the, I think, 225 patients you mentioned at Gibbs Cancer Center, did they see a comparable level of benefits with the different things you mentioned? And third, from all of that, are you seeing some optimal age or circumstances at which these therapies work the best?
So the first part, the age of the patients on the trial, I have to tell you I'm not certain of what the age was. I don't know that that was actually in the publication. I suspect that it is kind of, was in the early 70s, because that tends to be the most common age for men who are receiving radiation therapy. As for our program over at Gibbs, the 225 patients that we have treated, the only analysis that we have done thus far is an analysis of the dosimetry, meaning how much dose did the rectum receive for those patients versus patients who did not get the gel. And what we see, and that in what we analyzed was our CyberKnife population. So those patients who got CyberKnife treatment, which is a very short treatment course, and mostly we were looking at that because nobody else had really looked at that yet. Okay, so we wanted to be able to get our data out there, and what we found was really a very significant decrease, especially in the high dose area to the rectum, and in that volume of rectum receiving that high dose of radiation. We also saw that the volume of penile bulb receiving the high dose of radiation was very much lower. And I have to tell you, we did not consciously try to get that result for the penile bulb. It just so happens that when you don't have to work as hard to protect the rectum, you can actually protect the other structures that surround the prostate without even really making a huge effort to do that. And so we certainly saw those improvements in the dosimetry. Now, we're in the process now of collecting our data for the quality of life outcomes. So I don't have a firm answer for you on that. What was your third part? Or
is there an optimal age or circumstance for this therapy?
So I don't think that there is an optimal age for the use of Spacer. Nor is there really an optimal age for the use of radiation therapy in general. Now, it has been our inclination as radiation oncologists and as part of the urologic oncology community that young men with prostate cancer, we tend to steer them more towards surgery. They have a long time to develop potential side effects from things. They have a long time to have a recurrence of disease, and having radiation as your fallback position if you need it in the future is very important for those very young men. We also know, though, that as men age, the potential for side effects from surgery goes up quite dramatically starting at about age 70. And the primary one we're talking about here is urinary leakage and incontinence. That if you look at a 70-year-old man, he's starting to have issues. If you looked at him at age 60, he would do great with surgery. If you look at him at 75, he has a very high probability of having incontinence and leakage issues if he gets surgery. On the other hand, if you look at radiation side effects, though they are somewhat different than those for surgery, you'll find that that there isn't as much of an association with age. That is, if we treat a patient at 60 or 70 or 80, they tend to do relatively the same. Whereas with surgery, if you treat them at 60, they're doing great. At 70, things are starting to go sideways. If you treat them at 75 or 80, they're very likely to have incontinence and leakage issues. Yes?
Did you ask a question?
I don't have a question, but I do have comments. I was a patient of Dr. Fried 1 year ago, September. I was 77, so I fall into that older group, although I think of myself as being very young. I do want to talk about side effects. Nurse Kim over here at the Gibbs Cancer Center, I do want to recognize I had minimal side effects. I had none of those that were described there. My side effects were a little bit of fatigue, and that's just about it. So I thank you for the Spacer. I think it's a wonderful procedure.
So, well, I'm so glad to hear you say that.
I'm glad to be here tonight. African American, sometimes we have an enlarged prostate. And we have to test everything and they get it fixed or repaired, and then we feel that there's no chance for us to get prostate cancer. But we do. And a lot of them stop being treated, coming for surveillance, having doctors to examine them. I feel it's very important that you share that with us tonight. And I also learned that if you've had radiation, you cannot have, if I'm correct, let me know if I'm correct, we cannot have what you just presented tonight.
If you've already had
If
radiation?
you've had radiation, just general radiation, is that it? Or can you? Before you do, you have to have this before you have radiation.
Correct.
Right? Okay.
So this is something, it really, so there's nothing therapeutic about it, so to speak. It really literally just puts space between the two structures so that you can treat the prostate to a high dose and not give as much of that high dose of radiation to the rectum.
True. I appreciate that, and I'm so glad the Spartanburg group came tonight to witness this and be a part of it. Thank you so very much.
Well, thank you for being here. Yes.
For those of us that have had prostatectomies, what would be the procedure in the case of salvage radiation? Would the space oar still come into play, or is there still a prostate bed, so to speak?
So that is a very good question, and one that the answer is a little bit in flux right now. So there is not an official designation for the use of SpaceOAR in the post-prostatectomy setting. That is, if you have a recurrence of your prostate cancer after you've had surgery, then that was not what was tested in the study. However, there are some practitioners around the country who are starting to do this, and it is something that, in fact, at our big national meeting last week, that there was some discussion of. And so I think that there is some potential that in the future we may be able to do that, but right now it certainly wouldn't be the standard approach.
So, and post prostatectomy with a rise in PSA, would the most susceptible or suspected site be that prostate bed? Or?
Yeah, so the most common place for a recurrence, and it depends a lot on the pathology report as well. So when I talk to patients, and I talk to them very frequently about a recurrence of prostate cancer after their prostate has been removed, the first thing that we do is take a look at their pathology report together. Okay. And then we look at things like how long has it been since your prostatectomy? And what are the kinetics of the PSA rise? Did you have a long period before it started to come back, or did it come back right away? Or maybe even it didn't come down completely at all after your surgery. All of these things help us to get a sense of where the cancer may be coming back. But the prostate bed is the most common place for it to come back, just sort of you look at all comers. The other thing is there is a new type of scan that is available now that's called an Axumin scan, which is a special kind of PET scan. It's a fluciclovine PET scan. This is based on a molecule that was developed, or tracer that was developed at Emory University. Just got FDA approval, I want to say maybe 8 months ago or so. And that is specifically designed to find prostate cancer recurrences. So it helps us to define, well, is it really coming back in the prostate bed, or maybe it's in a lymph node somewhere that if we treated just the prostate bed, we wouldn't actually cover that area. So it helps us to better define where the cancer may be coming back, and I think it's a very important tool that is coming into more popular usage now. Yes?
Doctor, does the SpaceOAR procedure allow you to treat a higher grade and higher Gleason score cancer than you would have treated before, because now you could increase the radiation dosage?
So that's a great question, the one of dose escalation. Can we treat to a higher dose now? Maybe that expands the group of patients that would be eligible. And the answer to that is we think yes. In fact, there are some good studies going on currently, especially at University of Texas Southwestern with Dr. Bob Timmerman, who is very well known within the field of radiation oncology for doing SBRT, that is these short courses of radiation where we try to drive the radiation dose very high over a short number of treatments rather than spreading it out over many, many weeks. And what he is finding is that in patients that he wants to do dose escalation for prostate cancer, that if you escalate the dose without SpaceOAR, then you run into very bad problems with rectal toxicity. And in fact, in his dose escalation trial, and I have to tip my hat to him for having had the willingness to put forth some data that a lot of people would be afraid to put out there. But in this study, several of the patients wound up with colostomies because the dose was escalated very high and there wasn't a good way to keep the rectal dose low. But now he is running dose escalation trials with Spacer, and actually when I spoke with him about this several months ago, he said he would not do dose escalation without Spacer. So, and I think that that is going to make it so, especially for those patients with intermediate risk cancers, that we can now do a shortened treatment course for them very much more readily because we'll be able to drive that dose higher. Yes?
Yep, we have a couple of questions that came in online, if we can kind of mix them in a little bit. But the first one is a woman writes, 2 years ago, my husband had a wedge resection to his lung to remove several suspicious lesions. The lesions were positive for prostate cancer. More suspicious areas are showing on the recent scans, and we are wanting to know if it is feasible to have radiation to remove those areas rather than surgery. He's otherwise symptom-free and a 16-year survivor who is just finishing up Provenge treatment, receiving Eligard 6 months and Casodex.
So it's a little bit difficult to answer that question without knowing a bit more, but let's just say this. First of all, so that all of you know, a lung cancer, a lung metastasis that is spread of a prostate cancer to the lung is quite an unusual situation, and it is typically only seen for very high-grade cancers. And even those, it's a very small percentage of the cancers that will develop a metastasis in the lung. Now, bone metastases, much more common, but going to someplace like the lung or the liver or the brain, going to be very unusual. So this already is an unusual situation. Depending on the number and location of any other metastases, they may or may not be amenable to very focused radiation. For example, we do often treat very focused radiation to the lung for metastases from a variety of different cancers, and typically that can be done in somewhere between 3 and 5 radiation treatments and is very highly effective for controlling the disease in that specific location. Now, it does not address the more sort of the wider issue of systemic disease. That's something that, you know, hormone therapy, Provenge, other things like that are really more designed to do. And some of these new sort of souped up anti-androgens, abiraterone, and other things like that are helpful at controlling systemic disease. But if you have only a very few spots of metastatic disease, then that is something that we refer to as oligometastatic disease. So as opposed to a diffusely metastatic disease, we're talking about oligometastatic disease, disease that's only present in a few locations. And we're starting to come around as a community in oncology to thinking that we should probably go after those individual spots aggressively and that we may be able to get better long-term control of the disease that way.
Okay, we have another online question. Can you define EBRT and MIRT and SBRT and started fraction and any other sort of radiation therapy?
Okay, yes. Sorry, a little alphabet soup there.
Right. And the second part of that, excuse me, can you distinguish between photon radiation and proton radiation, or PBT? Thank you.
Yes. Okay, so let's talk about sort of the alphabet soup of radiation oncology. So broadly speaking, when we're treating with radiation, we refer to this as EBRT, external beam radiation therapy. And typically this is done with photons, which are X-rays. This is the most common way of treating prostate cancer with radiation. Now, IMRT is the most advanced way of treating that long course of radiation therapy that's typically given over about a 9-week course. So this allows us to, and this is what's called intensity modulated radiation therapy. It allows us to have very steep dose gradients. So you can have a high dose region and then a very sharp fall off and a very low dose region right near it. And so in doing that, we're able to do a better job of targeting the prostate and sparing the normal tissues. We can also do things like treat the pelvic lymph nodes, where we treat those regions where the lymph nodes live, but we can also do a good job of sparing most of the bowel and the bladder. So let's see. What other acronyms were?
Let's see, radiation. Photon and proton radiation.
Okay, so photons versus protons. So photons are essentially X-rays. Now, X-rays are what we most commonly use to treat when we're using radiation therapy. When people talk about radiation therapy and they don't make any other distinction about what it is, they are talking about photons. This is what, when people talk about a linear accelerator or a radiation-producing machine, they're talking about photons. Over the last couple of decades, there has also been a growth in the use of something called protons. Now, protons are different from photons. It's also radiation, but this is using a different form of radiation. There are only a few centers in the country that do protons. Actually, that number is growing as the cost of proton centers has come down. In the treatment of prostate cancer, there have been a number of studies now looking at photons versus protons and asking the question, well, is one better than the other? And the contention had never been that they would cure cancer differently. And in fact, I think we see from all the studies that they work equally well at controlling cancer. But the contention was that protons, because of how they interact with tissue, and I won't get into the specifics of that, but because of how they interact with tissue, would cause less damage to normal surrounding structures. But it turns out, over a bunch of studies that have looked at this over the last several years, that there seems to be no difference in the rate of side effects or toxicity for protons versus photons. And in fact, what we've seen is, in terms of reimbursement, that protons used to reimburse about 3 times as much as photons, but now that has come back down so that protons are reimbursing fairly similarly to photons because insurance companies and Medicare know the data that basically states that there's not a big difference between the two as far as their ability to protect the normal structures.
Okay, another online question. We have another one, in-person question over there too? Okay, I'll do one more here and I'll run over. I'm sorry, I can't see you around the pillar, but I'll come over there in a second then. Can gel spacing reach high enough to space SV and adjacent lymph nodes from rectum wall?
Okay, so this is asking, can the gel spacer be placed high enough to basically get between the SV, which is the seminal vesicles, and the rectum, and can you somehow space the lymph nodes away with that as well? So the short answer is that yes, you can get the gel up where the seminal vesicles are, and sometimes if you're not careful, it can go up there even when you're not intending for it to, in fact. So if you wanted it up there, you could in fact get it up there, but I don't think we have any information to say that we can do anything about pushing lymph nodes away from the rectum if we want to treat the pelvic lymph nodes. Having said that, even for patients where I am treating the pelvic lymph nodes, I still do use the gel in that space to push the prostate and the rectum away from one another.
Quick. So JB, so you'll be happy. But anyway, sexually, man, I mean, you mentioned that a few minutes ago. By sex.
Pardon, say that again?
Sex.
Sex, yes.
Yeah, yeah. That's the reason why a lot of guys don't want to have it done, you know.
Sure.
But I'm just saying, so what I need to do, take the 2 blue pills? Look at JB.
So with any treatment for prostate cancer, there's definitely a potential issue for damaging erectile function. Okay, so if you look at patient-reported outcomes for surgery, for example, somewhere between 50 and 80% of men who had good erectile function at the outset, if you ask them afterwards, they will tell you that they have had significant diminishment in their erectile function. If you look at radiation-based treatment, There is also a significant risk of inducement of erectile dysfunction, though it tends to be maybe slightly less than that for surgery, but it's certainly not a given that if you get your prostate treated with radiation that you'll maintain erectile function. I think it's fairly clear that either way has a high potential for causing damage there. Also, for some patients getting radiation for prostate cancer, they are getting hormone therapy as a component of that. Now, hormone therapy suppresses testosterone, and testosterone is directly linked to erectile function. So for those patients, we know it's basically a given that for at least some extended period of time, they won't have any erectile function, and then we have to wait until after the testosterone recovers to find out whether they've recovered their erectile function. So the question is, are there freestanding proton centers? Yes.
And I was reading about Hampton University. They had some kind of proton center and moved from Europe or somewhere they got a gift. But I just didn't understand.
Yeah, so there are a number of these centers around the country. The closest one to us here in South Carolina is actually in Knoxville, Tennessee. There's one in Hampton, Virginia. There's one in Jacksonville, Florida. The first two that were really in wide use in the country, one was out in California at Loma Linda University, and the other one was at Mass General up in Boston. Since then, there's been a proliferation of these centers. There's one at MD Anderson in Houston, and a number of others that are relatively new centers, and others coming online in the coming years. Part of the reason for that is that the cost of proton centers has come down significantly. So it used to cost anywhere from $100 million to $250 million to build a facility like that, and now that has come down into the $50 million range, which still is a lot of money, obviously, but it's significantly less than what these centers used to cost.
Okay, Johnny tells me we have time for one more question. I've got one online here that the question is, does the gel get in the way of fecal elimination?
So very good question. Does it get in the way of fecal elimination? So what we find is after we do the procedure, there's a small percentage of patients who feel kind of a sense of fullness in the rectum, almost like they have to have a bowel movement, but they don't really have to have one. But that, if it happens, goes away in a day or two. That there is no evidence whatsoever that there's any blockage of the rectum that would decrease the functioning of the rectum or have any significant change in bowel function. So no, actually, we don't see any of that. All right, thank you all very much. I appreciate it.
Thank Dr. Freed. Yeah. I always have to be the bad guy. And cut this off. And we thank you because this is really good because we see how passionate our men are in this area, in the upstate, about learning about prostate cancer. And that's a good thing. And so, but we'll have Dr. Freed back again. Hopefully we can have, I'm so excited about this online. And thank you for folks joining in online. It's the first time we've done it here, and I hope we get an opportunity to do it again.